My network is unstable, right? This is what I'm getting the message. Wait, I should join that my other one, USB network as well. Otherwise, yes, now it's better. So, Dr. Mohammed, are you ready?
Okay, ma'am, I am ready.
Okay, I'm starting the timer.
Okay.
Started the timer, and here is the question.
As a critical care.
Yes,
Okay.
yes, please. Right. If you have read and understood, considering it critical care scenario, how are you going to manage this patient further? What would be your next step?
Yeah, the manage the patient according to the ABC approach of the CRISP protocol after airway assessment and the treatment, and the breathing assessment and the treatment, and circulation assessment and the treatment. Patient regard the case scenario undergo a laparoscopic cholecystectomy for necrotizing cholecystitis. Patient get
Yes.
hypotension.
Yes.
I will resuscitate the patient with the crystal light, and
Yes.
reposition the patient to the lateral side and pull the graft uterus to the left side away from the IVC, and raise the patient leg and head down to 30 degrees to increase the venous return and decrease the cardiac output and decrease the blood pressure.
Okay.
And
Can
my
you tell?
professional
Yes. Yes.
diagnosis could be hypotension due to pneumoperitoneum because of insufficiency of the pressure CO2 more than 12, and could be due to adrenal insufficiency, and could be due to hypoglycemia, and could be myocardial infarction.
Very good. Can you name few functions that how would body response because of decreased blood pressure? What
Yeah,
would be
the
the immediate response of the body? Yes.
Yeah, the body response as autonomic response to decrease venous return and decrease the preload lead to decrease the cardiac output and decrease the arterial pressure according to the Frank Starling mechanism by reflex as baroreceptor located in the carotid sinus and the aortic arch. This is the baroreceptor stimulates sympathetic activity, produce compensatory tachycardia, and increase systemic vascular resistance, and decrease stroke volume and peripheral physical constriction, and decrease cardiac output, and increase blood pressure. And as hormone as catecholamine, الادرينال medulla stimulated by the pain and the injury released to the hormone to
Yes.
increase the systemic vascular resistance as noradrenaline, and the mineralocorticoid as adrenal cortex stimulate to release a hormone lead to salt and water retention and decrease the blood pressure as cortisol, and the reduction of the circulating blood volume and decrease the sympathetic activity stimulate renin release from the macula densa of the juxtaglomerular apparatus of the kidney, stimulate renin and angiotensin aldosterone system to stimulate the salt and water retention and the excretion of the potassium, and help to restore circulating volume over several hours.
Very good. Can you tell me how does the body detect low blood pressure? Tell me about the baroreceptors.
Yeah, the baroreceptor, this is mechanoreceptor located in the carotid sinus and the aortic artery. This is the function since the pressure changes by respond to changes in the tension of the arterial wall. This is supplied by the nerve of the hearing by the glossopharyngeal nerve, lead to sympathetic stimulation, lead to reflex tachycardia and decreases stroke volume and decreases systemic vascular resistance by peripheral vascular constriction and decreases cardiac output and increase blood pressure.
Very good. Can you please tell me how can you improve the preload of this patient?
The improve the preload of this
Preloads?
patient. Yeah, improve the preload of this patient by the resuscitation the patient and the inotrope and the vasopressor agent.
In fluids as well. Okay, can you please tell me about the inotropes? On which receptors these inotropes are going to act? What is
Yeah,
the action, mode of action of inotropes?
yeah. The inotrope, like adrenergic agonists like adrenaline and noradrenaline and isoprelane, lead to increased systemic vascular resistance by vasoconstriction and decreases stroke volume and the heart rate and decreases cardiac output to increase systolic blood pressure. And the dopaminergic effect like dopamine and the dopamine and the dobuxamine lead to decrease systemic vascular resistance by produce vasodilatation and decrease heart rate and the cardiac output and stroke volume and the contractility and decrease blood pressure and depend the dose of the dose to require to increase the blood pressure.
This patient is undergoing laparoscopic cholecystectomy. Would you go ahead with the laparoscopic cholecystectomy or would you convert it to open cholecystectomy, and why?
Regarding the case scenario, because of the effect of the laparoscopic cholecystectomy for this lady, the benefit to change to open cholecystectomy to avoid the systemic effect of the neoperitoneum, lead to decrease cardiac output and the venous return and the hypotension and decrease functional residual capacity and decrease splenic blood flow and to avoid the compression of the IVC by enlarged uterus and avoid of the sepsis and the infection mild to septic shock and the induction of the preterm labor and lead to intrauterine fetal death and the DVT and decrease uterine blood flow and decrease visualization because of the graft uterus.
Very good. How would this low blood pressure affect the fetus as patient is 35 weeks pregnant?
Yeah, the blood pressure affected because of the compression of the IVC by the uterus lead to decrease the venous return and the decrease the preload and the decrease the cardiac output. The second, the cause may be due to reverse trend the limberic position and may be due to sepsis from the necrotizing cholecystitis and may be due to blood loss from this patient.
Can you please tell me what is the effect or mechanism of preload to venous return?
What's mom?
Can you tell me the effects or mechanism of preload to venous return? How does it take place? There are 5 points.
Yeah.
Muscle contraction. Yes.
Yeah, like muscle contraction. The contraction of the
Yes.
limb muscle during swimming and the walking promote venous return by the muscle
Yes.
mechanism. And the second, during inspiration, the venous return increase because of decreased
Yes.
right atrial pressure. And the third,
Yes.
the mechanism by the gravity decrease the venous return, and by the vena-cava compression
Yes.
during the falcifa maneuver and the late pregnancy decrease the venous return. And during decrease the venous compliance by sympathetic activation of the vein, decrease the venous compliance and decrease the central venous pressure and the CVP, and promote the venous return by augmentation in cardiac output according to the Frank Starling mechanism, increase the total blood flow through the circulatory system.
Very good. Can you please tell me what is Frank Starling's law?
Yeah, the Frank Starling law is the greater in the diastolic volume by the volume of the blood enter the heart during the systole, and the greater diastolic volume, the volume of the blood ejected during the systole, and the vice versa.
post-operatively, where are you planning to manage this patient?
Yeah, the plan the manage in this patient post obstetric HDO.
Who would you involve in the management of this patient now?
Yeah, need the neonatologist and the obstetrician and the ITU registrar and anesthesia and the general surgery doctor.
All right, one last question, Bella is gone. Can you tell me some risk factors which occur because of laparoscopic cholecystectomy? What are the risks of laparoscopic cholecystectomy?
Yeah, the risk factor for a laparoscopic cholecystectomy, like intrauterine fetal death and the DVT of
Yes,
the longer duration, and the preterm labor, and the trocar injury to the uterus, and the decrease in uterine blood flow, and the decrease in visualization due to gravity uterus, and the fetal acidosis, and the
very
effect of
good.
the pneumoperitoneum of the pressure CO2 if the more than 12, and maybe lead to decrease the venous return and the cardiac output and the blood pressure, and the decrease the functional residual capacity and the splenic blood flow.
All right, okay. Can you please tell me how to prevent DVT, deep vein thrombosis, since it's the major risk factor post-operatively?
Yeah, ask IV hydration and the ambulization and the heparin and the
Very good.
embolic stocking and the intermittent pneumatic compression and the thromboembolic deterrent embolism.
And heparin as well. Okay, very good. Excellent. Good.
Thank you, ma'am.
Thank you. What about others? What do you think? Yes? Happy?
Yes, I am happy.
Yes, I'm happy.
Thank you.
Good. Anyone want to ask any question to Dr. Mohammed? Any comment? No? Anyone else would want to go next, or I can just continue with Dr. Mohammed? Dr. Zaid came.
Dr. Samreen?
Yes? Yes, please.
I have a few questions regarding the syntax of this exam, especially
Yes?
that Dr. Alain answered the previous question.
Yes?
Okay, you asked a number of questions from Dr. Sabin in a limited number of time, and he
Yes?
kept on answering the questions. I just wanted to
Yes.
ask that is all this detail required in the exam, or you can just name the the mechanisms of raising blood pressure, or you have to give this
Uh,
redundant detail, because there were a lot of
yes.
things in that answer.
Yes.
So
When
that's
you
why
are
I'm
asked about the mechanism, it depends upon the question as well. When you are asked about the mechanism, then you have to explain the mechanism as well. And in critical care scenarios, when you ask a question and then you ask why, then you have to answer it. If you'll go back and you'll listen to the recording again, you'll realize I asked him about the mechanisms and I asked him why as well. So that's why he was explaining. And in the beginning, when I asked him, how would you manage this patient? What would be your next step? So there I want him to, I allowed him to speak as well. But in exam, when examiner realizes that you're answering it correct, they may interrupt you and they may ask you another question. But like here, because people are listening and they are learning from the recordings, and I knew he was telling me correct, so I allowed him to speak. But then, well, the selected questions that I had to ask within the given time, I even kept on asking afterwards as well. So, yes, because this is practice, it's not official, it's just mock. So, yes, sometimes you have to
all right.
be very careful and you have to pay attention how the question is put forward to you. If they only want you to name the risk factors, just name them. I asked him to tell me those. He just told me which one was it. He just mentioned those, and that was enough. Yes, when I asked him to tell me the effects of preload and venous return, what is the mechanism, he just mentioned them, the 5 points, and that was enough. He didn't tell me in details. I didn't ask, but it's basically everything covers from the notes.
Hmm.
Yeah.
Okay. Thank you, ma'am.
That's all right. More questions if you have asked before we move on. That's all right. We are learning.
What are the
We are
total
just
marks?
4-5.
Total marks for this station, and how are these marks distributed for this particular station?
If I'm not wrong, then it's out of 20. I most of the time forget things as well. Then you can write in the group and ask. Some of the members have very good check on all these things, but if I'm not wrong, they are out of 20. Each station was
For one
before,
question.
yeah. No. One station was out of 20. Like 1 mark you'll get inside, you have greeted. Different stations have different marks distribution. So this one critical care scenario, like each question would have 1 mark. Some question might have only half marks. So they will ask questions, and most of the candidates, they answer questions within time, and they even get free for 1 or 2 minutes, and they sit and wait for the bell to go. So, but like how Dr. Muhammad answers, that's how quickly you have to answer the questions.
Okay, and the time window is 9 minutes.
Yes, considering COVID, it was 8 minutes, but now 1 minute extra, considering that bell will go and you would have to take yourself out.
All right, thank you.
But I give them 8 minutes and it's enough. But then if I want to ask them 1 or 2 questions, I can even continue and ask afterwards. It's just for the sake of revision, like one station has been completed as a whole. Yes.
Thank you.
Welcome. Would you be interested in presenting any station today?
Yeah, I will be interested, ma'am.
Yes. Which one? Any?
Uh, Something from the anatomy, because I'm a very beginner person and I would not be able to answer the physiology and critical care questions very effectively.
Okay.
So something from anatomy.
Okay. You started with the okay, wait, I'll bring something. Okay. I don't know where all my stations have gone. Okay, I've got something for you. Right. So if you're ready, can we start the timer?
Yes, Dr. Samri.
Okay, started the timer and here is your question. You'll be given 1 minute to read the question. right? If you have read and understood, kindly tell me if you can
Yeah, ma'am. Yeah, ma'am.
identify
I'm ready.
these structures. Yes, can you identify structure 11? What are you looking at right now? Can you identify?
This is a picture of cubital fossa
Very
dissected
good.
till the neurovascular bundle and muscles.
Okay. Can you please identify structure 11?
This is median cubital vein.
Very good. Can you please identify structure 2? 2 is here.
Uh, this is
2, please.
cephalic vein,
No, other one.
the basilic vein,
Yes. Yes. And this is 6 is?
cephalic vein.
Very good. Now it's supported. Yes. Okay. Can you please tell me the surface marking of cephalic vein?
Cephalic vein.
From where is it
Uh,
formed? Yes.
it originates from the dorsal venous arch and afterwards is winds around the thumb and passes over the anatomical snuff box and runs along the lateral border of the forearm and enters
Yes.
cubital fossa and is joined by the
Yes.
other tributaries and ultimately drains into deltopectoral groove.
In which vessel?
In
It
axillary
drains
vein.
into which vessel?
In axillary vein.
Okay, good. Okay, can you please tell me the boundary of cubital fossa quickly?
Cubital fossa is
Can you
uh,
please tell me the yes?
cubital fossa is bounded by cubital fossa is bounded by
Yes.
medially by
Spirolateral and
medial epicondyle, laterally by lateral epicondyle, and the line joining them in the center, and
medially by the pronator teres and spirolaterally by
spirolaterally
which
by
muscle?
biceps.
No, brachioradialis muscle. Okay, can you tell me the floor is formed by which muscle? Brachialis.
Floor is
Okay, can you please tell me the
brachialis.
contents of by the brachialis? And can you please tell me the contents of the cubital fossa from medial to lateral, please?
On the medial side, starting from the median side, the first one is median nerve, then tendon of biceps brachii, then brachial artery, and finally
Yes?
radial nerve on the lateral side.
No. Brachial artery and then tendon of biceps, medial to lateral.
Okay.
It's always like a relation of brachial artery has been asked. So it's very important you should know. Okay, can you please tell me the origin and insertion of biceps muscle?
Biceps muscle has two origins, and it inserts on the radial tuberosity
Yes?
on the radius,
Yes?
and the origin is
Yes? Which two heads? You have to go back and yes.
one origin is supraglenoid part of scapula, and the other is coronoid process.
Supraglenoid tubercle, yes. And coronoid process, yes. Short head and long head. All right.
Yes.
Can you tell me which nerve supplies it?
Uh, Coraco,
Which nerve?
musculocutaneous nerve.
Yes. Okay. What is the significance of cubital fossa? Is there any significance? If not
Cubital
cubital
fo-
fossa, then you can
cubital
tell me the
fossa. Cubital
significance of
fossa.
yes. Yes.
Cubital fossa is a common site for PICC lines and IV cannulation.
Yes. Yes.
And the blood pressure, manual blood pressure is checked upon the cubital fossa, 1 inch above cubital fossa.
Yes.
And that's it. PICC lines.
Can you tell me, yes, can you please tell me about attachment of the flexor retinaculum? Picture A.
Flexor retinaculum extends over distal radius from laterally, and its lateral extent is on the ulna, distal ulna, and it overhangs the tendons and the nerve and the carpus bones.
Can you please tell me what are the tendons which passes through the flexor retinaculum or below the flexor retinaculum?
9 tendons pass below flexor retinaculum, 4 tendons of
Yes.
flexor digitorum profundus, 4 tendons of flexor digitorum superficialis, and 1 tendon of flexor pollicis longus.
Good. Sometimes certain patients, they complain of pain while sleeping, or when they feel and they sense the pins and needle sensation. That could be because of compression of which nerve?
The median nerve under the under the flexor retinaculum.
Good. Okay, so what should be the treatment of that condition, and why does it happen?
The cause is entrapment of the median, or entrapment or compression of the median nerve under the flexor retinaculum, and that is called carpal tunnel syndrome, and the etiology is age related as well as pregnancy and thyroid disorder and other connective tissue disorders.
Occupation related, yes.
And especially typewriters, occupational related, yes. And the treatments are the conservative treatment, first of all, with the painkiller and the application of POP, plaster of Paris cast, in a posture to avoid the nerve impingement. And the surgical treatment is removing this flexor retinaculum band of flexor retinaculum, carpal tunnel release.
Okay. And avoidance of those professions.
And avoidance of the, yes.
Okay. Right. Would you be able to identify structure 16?
Structure 16. The time is over?
Yes. But you realized how slow you went.
Yeah, ma'am. I was
They
slow.
ask like a bullet, that's all right because you're practicing. They ask like bullet and you have to answer very quickly. So this 16 and then 25, I want to know. 16 here and then 25 here.
Ma'am, 16 is radial artery.
One of them is median. One of them is ulnar nerve and the other one is median nerve. Which one is which? Now I have to given you the hint.
One of this. Okay, 16 is median nerve.
Okay, and 25 is then ulnar nerve.
Yes.
All right. Okay. Since I've shown you this picture as well, so I want you to tell me what 29 is.
Ma'am, 29 is
and 30, 31 and 27. Just 4 of these I would want you to tell me, please.
29 is superficial palmar arch. 30 is
okay. 30
palmar brevis, palmaris brevis. I think 30 is palmaris brevis. And
all right, and then 27 and 31. 31 and 27.
Sorry, ma'am, that I don't know about.
Yes, you'll learn and then we'll discuss next time. Okay, what was the flexor retinaculum's attachment you told me? Proximally, it is attached to what?
The distal end of the radius and distal ulna.
No, pisiform and tubercle of scaphoid, and distally to the hook of hamate and trapezium.
All right, ma'am.
This is what I have. Okay. And then there are, okay. There are more questions, but then, yeah, next time we'll ask.
Thank you very much.
77 is radial artery. Thank you. Superficial, yes. Ulnar artery and radial, okay. What is no? Which, Dr. Fatumata, which one you wanted to repeat? Sorry, I wasn't looking at the questions.
I wanted him to repeat when you asked him about the tendon. So he mentioned 9 of them, but I could not get everything that he was saying. Yeah.
Can you please repeat the tendons passing through the flexor retinaculum? Flexor distrum superficialis, flexor distrum profundus, flexor pollicis longus, all 4, and flexor carpi radialis, flexor carpi ulnaris, and medial nerve. 9 of them. Yes? Yes? Good. Okay, Dr. Mohammed Ilyan, are you ready? Good evening, Dr. Ulfat. Can you please help? Communication skills.
Okay, ma'am, I am ready.
Okay.
Hello, Assalamualaikum, ma'am.
Yes, ma'am. Would you be able to help Dr. Mohammed?
All right, ma'am.
So if both of you are ready, can I start the timer?
Okay, ma'am, I am ready.
Yes, here is the question. Good. So if you have read and understood, kindly begin your station.
Okay. Good evening, sir. Hello, I am Mohammed Ilayan, one of the surgical doctor registrar working for Mr. Mann in X Hospital. I am calling to speak Mr. David to ask him advice about the patient. He undergo right hemocolectomy for sickle tumor. He has now oliguria now. Could I check that I am speaking to Mr. David?
Yes, Mr. David speaking. Please summarize your case, doctor.
Okay, 69 years old lady, post-operative 1 day, done a right hemicolectomy for cecal tumor with liver metastasis. Now the patient have hypotension and persistent tachycardia, and with the normal temperature, and the patient dropped the patient dropped the urine output from 10 to 20 milli every hour in the last 8 hours. After investigation, the hemoglobin dropped from the 12 to 10 and the creatinine within the borderline, and the urea 16. Done ECG normal, and the chest X-ray clear. By examination الابdomen soft lax. The patient after that assessment, the patient according to the ABC approach. I think the patient dehydrated the patient. I am requirement to advise about the patient and the opinion for management of this patient.
All right. Doctor, what do you think? What could be the cause of this oliguria?
I think the patient is dehydrated. He received 1,100 milli of the normal saline. Also, check the operative note have the blood loss, but received the patient 2 unit of the blood, and the hemoglobin dropped from the 12 to 10.
All right. How would you manage this case?
To manage this patient according to the ABC approach of the CRISP protocol, I will start fluid resuscitation by give 1 liter of the normal saline over 1 hour, and will continuously monitor the patient with the blood pressure and the urine output and the mental status and the capillary fill time. And I will repeat the blood tomorrow morning if not respond to fluid challenge over the night. And I will transfer the patient to the HDO to insert the center line and monitoring the patient. If the blood dropped the hemoglobin, I will start blood transfusion.
Okay. Have you read the OT note? Was there any blood loss intraoperatively? Doctor, did you read the OT note? All right. Yes. Hello. Yes. Hello.
Hello?
Can you hear me? Yes. Can you hear me?
Yeah.
All right. Doctor, how would you manage the circulation of this patient?
Manage the circulation of this patient by large tubor cannula in the antecubital fossa. I take full blood count, urea and electrolyte, and the blood group and the cross match and the EBG. Start with 1 liter of the crystalloid as bolus dose. If not respond, can be added 1 liter bolus dose of the crystalloid. If not respond, can be added inotrope. Would monitor the patient with the blood pressure and urine output and the mental status and the respiratory rate and the heart rate.
Who would you involve in the management of your case?
Involved in the HDO to insert the center line and monitoring the patient.
Who else would you involve? Any other faculty of medical science would you involve?
Yeah, maybe you need anesthesia doctor and ITU registrar and general surgery doctor.
Any nephrologist, perhaps?
Yeah, and the nephrologist doctor, because of the patient dehydrated with the borderline of the urea and the creatinine, maybe lead to acute renal failure because of the loss of the blood volume and the fluid loss by dehydration.
Okay. All right. Okay. What is the formula for the fluid challenge that you would give, doctor?
Good.
From the 30 ml every kilogram of the crystalloid, and from the 250 to 500 ml in the 15 minutes.
Okay. If the patient had, in the operative note, if the patient had said that there was blood loss, what do you think? What could be the most common cause of this blood loss per operative? You said the patient had a right hemicolectomy, so yes.
Yes, the bleeding loss may be due to injury of the vessels like superior mesenteric artery injury, because of the superior mesenteric artery supply the right side of the cecum and right side of the colon.
All right. If you need me to come, what would you do?
I will monitor the vital sign continuously, and I will do serial abdominal examination if they found any sign of the bleeding, and start the patient and the monitoring with the blood pressure and urine output, and the serial abdominal examination every 4 hours. If the stable resolve with the hematoma, if not respond, can be done CT scan to confirm the site and the location of the injury. If not respond to the conservative treatment, can be patient need laparotomy.
All right then, doctor.
Good.
Where would you manage this patient?
Manage this patient. Manage this patient in the HDO.
What are the criteria of management of this patient in HDO? Admission criteria of HDO, doctor.
Please repeat the question.
What are the criteria of HDO admission?
The criteria of one-to-one nurse care, and if patient need monitoring with the blood pressure and the urine output, if the patient hypotensive and the tachycardia, and the patient need Iotropes and vasopressor agent, and the patient need ventilation according to the mental status of the Glasgow Coma Scale.
Suppose I don't have any bed available in HDU. In that case, what would you do?
If not available in the HDO, can be transfer the patient to the ICU after consultation with the ITU registrar and anesthesia doctor.
Good.
Okay, doctor.
Causes of shock in this patient.
What would be the causes of shock in this patient?
The causes of this shock of this patient may be due to dehydration. Dehydration led to hypovolemia and may be due to bleeding from the site of the injury because of the injury of the blood vessels, and maybe due to the hypotension of this patient as a complication related to the anesthesia and the complication related to the surgery, like hypotension and myocardial infarction and adrenal insufficiency as a post-operative complication.
All right. Okay, doctor, if you could just summarize your case.
Okay, 69 years old lady, post-operative one, undergo right hemicolectomy for sickle tumor with liver metastasis. Now the patient have hypotension and tachycardia, and by investigation, the hemoglobin dropped from the 12 to 10, and the patient received 2 units during the surgery, and the investigation with the normal borderline of the creatinine and the urea, and the ECG is normal, chest X-ray is normal, and by abdominal examination, this is soft lax. After assessment, the patient according to the ABC approach of the CRISP protocol, I think the patient is dehydrated, and I will start the patient resuscitation the patient and monitoring the patient, and the patient maybe need the laparotomy and the nephrological consultation to detect the opinion for this management.
Good.
All right.
Thank you.
Thank you, doctor. Thank you, ma'am.
Thank you, doctor.
Right,
Thank
it
you,
was good. Right, one question. Acute renal failure, you said, because it's post-op day 1, and I think could be better if you can use the word acute kidney injury.
Yeah.
Instead of failure, because failure, it's acute failure can also happen, but then, yes, Dr. Ulfat.
Dr. Mohammed, if you you have to mention that you're going to check the catheters to see if there is any blockade or any kinking. Then you to exclude that.
Did you ask him about the output? Because 10 to 20 ml in last 8 hours, is it enough?
Ma'am, he already said that, ma'am. He said that it is oliguria. So I said, what are the causes of this oliguria? So he said acute renal failure. So he should also mention, when I asked about the management, you should start with, okay, I'm going to first check the catheter to see if there is any blockade or any kinking. After that, I'm going to check if the patient has been given adequate feed resuscitation. So I'm going to check the medication chart. And I'm going to see if the patient is receiving any
only
nephrotoxic
received
drugs.
1100 in
Yes,
last
only
24 hours.
1100. So that means it's not adequate. And also I'm going to see if the patient is receiving any nephrotoxic drugs. And I'm going to then hold those drugs. Then I'm going to give a fluid challenge and I'm going to monitor the patient over 15 to 30 minutes. If I see that it's not improving, I'm going to give a further fluid challenge. If not, then I'm going to consult with the anesthesiologist, the nephrologist, and the consultant surgeon. And if required, I'm going to even go for diuretics and at most even dialysis after consulting with the consultant surgeon and the nephrologist.
Okay.
Which diuretic would be best to go for?
This would be a furosemide
for this
diuretic.
patient.
Furosemide, yeah.
Diuretics.
Yeah.
Yes. Yes.
To improve
I
renal
asked
blood flow
not
from.
to say thiazide.
Thiazide, ma'am?
No.
No, I asked not
because
to say
to
that.
improve renal blood flow.
Yes. Yes.
Okay.
Good. Very good. But one thing is good that Dr. Muhammad is improving a lot. Now he can understand many of the members and he can spontaneously reply to them as well. So it's a plus plus from my side. It's good. When he'll be encountering a different examiner, yes, in that case, like when he'll be encountering different examiners, then he can manage any accent, anyone. So it's good. This is the beauty of this group, you know, it's multicultural, so one can get to meet people from all over the world. So it's plus. Right. Now, you joined Dr. Ulfat and Dr. Sunday and Dr. Fatumata. I don't know, maybe
yes,
any of you would want to share any station or
ma'am, is
not
there any
today, tomorrow?
communication skill station? I could go for it if there is any.
If there is any. Food will be prepared on order. We'll arrange one. We'll make it happen.
If it's there, no problem, ma'am.
Yeah, it's not a problem for me. Like, that's why we are here, you know, to practice.
Yes, ma'am.
So, who would you pick to help you?
Ma'am, anyone's fine.
Yes? Anyone want to help Dr. Ulfat? Dr. Sunday, would you be able to? Can we have your expertise? Good evening.
Hello. Good evening.
Yes, hello.
Okay.
Good evening. Thank you so much. If both of you are ready, can I start the timer?
Yes, ma'am.
Yes. Okay, here is the question. Now this is talking to a patient, not to the consultant. Thought
Yes,
we can have something
ma'am.
different.
Ma'am,
Yes.
I did that day. I did the same thing the other day. You gave me this random station.
Was it?
You
Doesn't
gave me
matter,
the
do it
same
again.
Oh, okay, fine, ma'am. No
Warfarin one.
problem.
Was it Warfarin one?
Yes.
I'm not really
Yes,
sure.
ma'am. Yes, ma'am. You gave me warfarin only.
So you want to change it to something else?
Yes, ma'am. Any random will do. I just did it recently, ma'am. I did it, in fact.
In fact, you did it.
Not a problem.
Okay,
Yes, ma'am.
Dr. Sunday, can you be the candidate? Dr. Ulfat will ask you a question.
Okay.
Thank you. So change the role and I'll bring the next one for you.
Okay, ma'am. No problem.
Thank you.
Most welcome, ma'am.
If you have read and understood, kindly begin your station, Dr. Sunday, as a candidate.
Hello. Hello.
Hello.
One of the medical doctor. So, can I just confirm your name and age, please?
I'm Jonathan. I'm 65 years old.
Thanks, Jonathan. Is that okay? So I understand that I'm asked to speak with you regarding your the procedure you're about to go for. Is that correct, right?
Yes, doctor.
Okay. So I understand that you want to speak with me, but before we get into that, can I just ask you what you know so far about your procedure and everything you've been told so far?
So I have been told that I have to stop a certain medication for this surgery. It's called warfarin, and I'm really worried about stopping it. You see, my GP has told me that I should in no circumstance stop this medication, as my cardiologist has given it to me, and because of my heart problem. So he said that, you know, if I stop it, then I might, you know, I could bleed and then I could die. So in no way I should stop this.
Yeah, Mr. Jonathan, you're actually correct about this. So I'm here to speak with you about this medication. So because of what you just told me, let me just add something to you. So this medication called warfarin, so it's basically be given to you so that it's called a blood thinning medication. So it thins your blood and prevent blood clots from forming, which can be dangerous for you. So, but because of this medication, we understand that it can be dangerous for you to use this medication while you're about to go for another operation, and that is why we want to change this medication for you to another one. Don't worry, the new one also does the same thing, just a blood thinning drug. However, the new one we're going to give it that is called heparin will be given through injection, and it works shorter, unlike warfarin. So, and this will help us, you know, to cope during the period of your surgery. And basically, what we need to do. Hope you understand me. Hello, do
Yes,
you
doctor,
understand
I'm
what I said?
understanding.
Okay, I
Yes,
continue.
doctor, but yes, doctor, I'm understanding. But why do you want to stop this warfarin, and why do you want to give this new drug to me? Can't I
Excellent
continue
question.
with warfarin because they're the same thing you are saying?
Yeah, that's an excellent question. So as I was saying, warfarin is a long acting drug whereby heparin acts in a shorter time. So this will allow us to be able to stop heparin before the operation because it acts in a shorter time. But if you keep taking warfarin, so it will be harder for us to stop it or to reverse it during the procedure, which can make you bleed on the table. Do you understand that?
Yes.
So, and basically, so in this case, this is what we usually do. About 5 days before the procedure, we have to stop this warfarin. Then we have to substitute it with the new drug, heparin, which you have to take through injection. And we suggest, you come to the hospital so that you can be under our care and we can watch you day and night and give you this injection. And about a day to your surgery, we are going to stop the heparin. And after the surgery, after performing some series of tests, knowing that the risk of bleeding has gone, then we are going to resume the heparin. And when you can start eating, through your mouth again, then we can start warfarin. And we need to run some tests, that will tell us whether it is safe to start the drug or not after your surgery. Do you understand that?
Yes, doctor, I'm understanding. A question. When should I, for this stopping the drug, should I get admitted to the hospital?
Okay, so about that. So I think it will be best if you come to the hospital so that we can look after you day and night. But if you want to stay at home, we could do that also. But that would require, us to arrange nurses or what do you call GP doctor to come look after you at home and your carer. But but if you come to the hospital, to be safer and it will be the best course of action. But it all depends on you.
Oh, then
On what.
okay. Then I better get admitted. How many days before the operation should I get admitted? You say?
So the best will be to be admitted about 5 days before the operation when you're going to stop the warfarin, because warfarin is taken as drug medication, so that you can start giving the injection for the heparin.
Okay. Doctor, another question actually. I take another medication. It's for my, my sleep, and I'm not being able to sleep. So I'm given diazepam. So can I take that, or should I stop that too?
Yeah, about that. So you don't need to stop that. You can continue that medication. Perfectly fine.
Okay, so I can continue that. Okay. And you're going to give me the new medication, and you're going to stop that after the operation is over. Yeah. And then I can get back to my warfarin?
Yes. So
okay, just like
after
before?
the operation, okay, continue please.
Okay, all right. When after the operation can I get back to warfarin?
So back to work. So it depends on how your rehabilitation after the operation. So normally within few days you should be able to go back home and go back to your normal life. But before that, you have to run some tests, to be sure that you have the risk of bleeding is gone and that it is safe to start warfarin again before we can do that.
Okay, doctor. All right. Thank you so much.
Thank you. So do you have any other question?
No, doctor. Not at the moment. Thank you so much.
Okay, thanks for your time. And
then you can summarize.
Yes. Can I just just summarize what we've been through? So today
yes, sure, doctor.
Regarding the change of medication for you from warfarin to heparin, which I told you they both act the same way. They're both blood thinning, and I told you why we are changing it, and when we're going to start, and when we are going to stop, and how we're going to restart the medication after operation. Is that correct? So
yes, doctor.
And have you decided? Do you want to stay in the hospital, or do you want to keep taking this drug at home?
I think I'll best get admitted in the hospital.
Okay, that's fine. So I will get everything started, and we are going to schedule when you're going to come to the hospital to start your medication, and I will get this in touch with my senior. Thank you for your time, and thank you for speaking with me. And I want you to know that we are here to help you and to support you. So if you need any further questions, please you can get in touch with the nurses, and they will contact me. Thank you.
Thank you so much, doctor.
Very good. Just 10 seconds left. Good. Now bell went. Okay. Any feedback you want to give to Dr.
I think
Sunday?
he did really good, ma'am.
He did well.
He did really good.
Of
Yes,
course.
Within time and summarized everything good.
Yes. Very good. Okay, now I should look for a station for you, and then you can have help. Okay, this is something, I don't think you have done this before, hopefully. So, yes. Dr. Sunday, would you be able to help her?
Yes.
Thank you. Okay. So I've started the timer, and here is your question. Right. If you have read and understood, kindly begin your station.
Hello, good morning. I'm Dr. Ulfa Jahan, one of the examination candidates. Can I please confirm your name and age, please?
I'm Mrcs, 50 years old.
Nice to meet you, Mrs. Merkel. So I've been asked to speak to you regarding your condition and the blood tests that you have currently done. We have the reports at hand. So would you like me to continue?
Yes, doctor.
All right. So before we begin, could you tell me more about what do you know about your case?
So, doctor, it just started with a lump that I had on my breast, and at first I thought it was nothing. So, and then I got checked. I went to the hospital, and they said they have to run some tests, and they took some, I think, biopsy, and after that, I underwent the chemo section and the radiotherapy 2 years ago. So, and now they said they want to run some further tests, which I'm here to, to get the result for the test. And
All right.
I'm scared.
Okay. It's all right. Don't
Doctor,
worry.
no
Yes.
cancer.
Okay, Mrs. Merkel, let's start, yeah? So before I begin, would you like to involve someone else, perhaps a family member whom you would wish to also share this news? Then I could perhaps talk to and explain the reports together to you both. Is there anyone else you would like, or?
I think I'm all right. You can proceed.
All right. Okay, then. So, Mrs. Merkel, you see, you have had this tumor in your right breast, right? And you had an operation. And after that, you had chemotherapy, you had radiotherapy. And as your report says that you were doing well, yeah? But I guess the recent reports that have come, they are a bit indicative and not really favorable. All right? So the reports actually suggest that there could be a chance that the tumor has recurred and has, spread to some other part of your body, perhaps your liver or your bone. Are you understanding me?
Doctor, hold on, please, doctor. Did you just say the
So,
tumor has returned? Oh
I'm
my
sorry,
God.
I didn't understand. I'm so sorry.
Tumor
I'm extremely sorry, Mrs.
Yes.
Merkel, to break this down to you, but you must understand that in some cases, such as yours, even after the complete treatment, there is a chance. I'm sure your physician and your oncologist must have shared this with you prior to your management of and also surgery, that there would be a very slight chance of recurrence, right?
Yes, I was told, but I thought I already defeated this cancer. And
I'm so sorry, Mrs. Merkel. I totally understand, and my sympathies for you. But unfortunately, your report suggests something like this. So what we could do is we are going to take biopsy. We are going to do further scans. Yes, to identify exact location, and we're going to also see how much it has spread. Yes.
hold on, doctor. So are you saying the cancer is not just it's not just in one location, it has spread?
Yes,
Doctor,
unfortunately, the reports.
am I going to
Yes.
die? Because I don't want to die.
No, Mrs. Merkel, no, please don't be so disheartened, and no, don't worry, don't be so low. This is a cancer, and we cannot promise anything. But we're going to try our level best to, ensure that, you're not suffering. Yes, we're going to get to the bottom of this. Okay, don't worry. We're going to do some CT scans. All right, we're going to run some tests, more further blood tests, and also we're going to speak again to your oncologist. Yeah, are you following me?
I'm following you, but can I just ask a question? So,
All right.
is
Yes.
it? Do you think you can cure this cancer again? Is there any chance?
Actually, right now we are only seeing some blood tests. We'll have to do further tests to determine how much aggressive this tumor is. And normally when it has spread, usually we have to go for palliative treatment, which actually means that we do not have a definitive treatment. We cannot completely cure the cancer, but we can reduce your pain and any other symptoms that you may be having. So in the light of this, could I please ask you, do you notice anything new, or have you noticed any new symptoms that you might have?
Not really. Just that I've been feeling, overly tired lately.
Mm-hmm.
So, and probably my appetite have not remained the same. So, and I've been anxious and scared.
Okay. And do you have... All right. Okay. I'm so sorry. Can you please tell me, do you have like any bone pain or muscle cramps, or do you feel, itching around your body, or maybe you notice yellowish discoloration of your skin or your urine, something like that?
Doctor, right now I have no idea. I don't even know what to say, because I'm just... I can't stop thinking of what you told me.
It's all right, Mrs. Merkel. It's totally natural for you to feel like that. I'm so sorry for this. I'm so sorry to break this down to you, but you see, this is what has happened, and I'm going to now going to refer to you an oncologist, okay? And they're going to continue, and they're going to give you some further protocol of management. Yes.
Okay.
All right. And all right then. So, and I'm going to also write down for some more tests, okay, after speaking to my consultant, like some, perhaps we'll have to do some CT scan of your chest, of your abdomen, of your tummy. And also we'll have to do some more further blood tests to see the status, how your breast cancer is, what's the grade it is in. Yes.
Okay.
How severe it is. Yes.
Come again. I didn't get that.
We're going to do some more tests for you. Okay, Mrs. Merkel. We're going to advise you some CT scans for your whole body to see where exactly the tumor is and how much it has spread and how bad or aggressive it is. Yes, so that we can tackle it. Yeah.
Okay.
And perhaps you might even require further cycles of chemotherapy or radiotherapy. Yes, you're following me.
Yeah, but doctor, about that, the last chemo cycle that I had, it was really horrible for me. I lost my ears, and I'm really, I don't know, is there any way around that?
Oh, all right. I'm so sorry to hear that. But Mrs. Merkel, just to inform you, chemotherapy and radiotherapy is really a very, aggressive treatment, and a lot of patients. It's very common for patients such as yourself to face this kind of symptoms. Yeah, side effects from the chemo and radiotherapy. So rest assured, whatever these side effects are, usually they are all reversible. That means after you stop the treatment, you will be relieved of these side effects too. Yes. And also, while we are giving you this chemotherapy and radiotherapy, we'll also be giving you some more medication side by side so that they don't bring about these side effects. Okay. Yes.
Okay. That's all right.
All right then. All right, Mrs. Merkel, if I could just summarize for you. So you do understand that you had a breast cancer 2 years ago on your right side, and you had a surgery, and after that you had chemotherapy and radiotherapy. Unfortunately, the recent tests that have come suggest that there is a chance that the tumor has again recurred and has spread to some other parts, perhaps your liver or your bones, okay, or your spine. So we're going to do further tests. Yes, I'm going to write them down for you after consulting with my consultant surgeon, and also will perhaps refer to you to an oncologist. Yes.
Yes.
Yes. All right then. All right. Mrs. Merkel, do you have any other question?
No.
All right. Thank you so much, Mrs. Merkel. If you do have, I'm going to leave my number at the nurse's station. So if you want, you can totally contact with me. Yes?
Okay.
Thank you so much. And again, extremely sorry for this. Thank you.
Okay.
Thank you. Good. Yes, it was not our usual station, so maybe
yes,
you went
ma'am, I have...
2 minutes above the, but then
so
on the
sorry,
other side, you had Dr. Sunday, who is quite professional, you know. So he acted very well on the track.
Yes.
And he
was
kept
a good
you on the
Mrs.
track.
Merkel.
Yes, very good, very well educated one, actually. What was your experience, Dr. Sunday?
Yes, so yeah, my comment.
Yes.
She did well,
Yes.
and she tried to show empathy at
Yes.
any given time.
Yes.
However, when she didn't give me any warning shots before throwing the bad news,
yes.
And she didn't give time to process it. So those 2 points, I think, they are very important when giving bad news. Because she does
I think she kind of asked you if you want to have someone from your family member with you.
That was privacy, but when she was communicating, she
yes.
just went straight to the point. She didn't give me warning sign that something. Then when I said, I tried to come in like, wait, but she didn't. Then she didn't give me enough time to process, because that's the bad news. When you give someone a bad news, you give them few seconds to probably process the news. After that, anything you say, they probably will not listen. So that's just one thing. That part is the only thing that I know that she needs to work on.
Good. She'll go back, she'll listen, and she'll improve on that one. Because the reason was to give you a scenario which is not common, and to see your expertise or your how well you are in communicating something new given to you at your hand. So I think you did pretty well. But then those 2 things that Dr. Sunday has pointed out, you can go back, listen, and then you can improve on those for next time, hopefully.
Totally, ma'am. Yes, ma'am. Totally, ma'am.
Good.
Thank you, ma'am. Thank you, Dr. Sunday.
Thank you.
Good. Right. Anyone else want to practice anesthesia, or we can call it the end? Yes? No? Dr. Fatima, do let me know when you're ready, okay? I'm not going to stress you, but whenever you are ready, you let me know and we'll begin. So I'm just stopping the, if no